Hi friends, in this topic of general examination, today I will talk about edema. First is the disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. As we know that fluid compartments in the human body are divided into intracellular and extracellular spaces. The extracellular space constitutes about one third of the total body water, and it is further divided into intravascular plasma volume, that is 25%, and extravascular interstitial space, that is 75%. The fluid balance between these two compartments is maintained by the hydrostatic pressures and oncotic pressure, which we have which has been described by the Starling. The two important other factors in fluid balance are vessel wall permeability and lymphatic system. The lymphatic system collects the fluid and filtered proteins from the interstitial space and returns that back to vasculature. Any disturbance in this delicate system results in net filtration out of vascular space or impaired fluid returned by the lymphatic vessels, leads to fluid accumulation in the interstitial space, leading to edema. So edema can affect any body part and can range from local swelling to full-blown anasarca depending on the underlying pathology. We can define edema as abnormal accumulation of fluid in the interstitium. Where do we see the edema, or what are the sites which are most commonly affected by the edema? In mobile patient, in bedridden supine patients, sorry, in mobile patients, we can see edema in leg 2 to 3 centimeter above the medial malleolus, and in bedridden supine patient, sacrum and the backs over the scapula. And if we want to check the edema in the abdominal wall, we have to pinch the skin over the abdomen. How do we assess edema? We just press the skin and subcutaneous tissue for at least 15 to 20 seconds against a bony prominence. This is not for abdominal wall edema. In abdominal wall edema, we pinch the skin and subcutaneous tissues. How do we grade the pitting edema? Grade 1 is 2 mm depression and there is immediate rebound. Grade 2 plus is 4 mm deep pit and it takes few seconds to rebound. Grade 3 plus is 6 mm deep pit and it takes 10 to 12 seconds to rebound. Grade 4 plus is 8 mm deep pit and it takes more than 20 seconds to rebound. Coming to pathophysiology of the edema, just remember two important key steps. First is the fluid leakage, that is changes in the capillary hemodynamics leads to fluid moving from the blood vessels into the interstitium, that is tissue spaces. And second is the fluid retention. The kidney, they retains the sodium and water to compensate for fluid loss by the renin angiotensin aldosterone system. So the important key factors which are involved in the pathophysiology of the edema are increased hydrostatic pressure as seen in venous obstruction, plasma volume expansion. Second is the decreased oncotic pressure because of low albumin level, neurohumoral cascades as seen in heart failure, liver cirrhosis, and endothelial derived factors, that is nitric oxide, prostaglandins. The various causes of edema, important causes of edema are congestive heart failure, liver cirrhosis, nephrotic syndrome, hypothyroidism, lymphedema, idiopathic edema, and certain medication like calcium channel blockers. They are important causes of edema which I am discussing in the next slides. So whenever we are examining any patients of the peripheral edema, we have to take the proper history and do the physical examinations. In the history, we have to assess the timing of the edema, whether it is acute or chronic. Acute is if it is of less than 72 hours duration, and chronic it is more than 72 hours duration. Whether it changes with the position, improves with the elevation, or worsens with the dependency, whether it is unilateral or bilateral, we have to take the proper medication history and also evaluate the whether there are other system involved with the peripheral edema or not. In physical examination, we have to assess the edema for pitting, pitting, that is pressure, pressing the skin over the bony prominence, especially on the shin bones, and we have to see for indentation whether edema is associated with tenderness or not. Other skin changes over involved with the edema like redness, warmth, thickening. We have to look for signs of systemic diseases. For example, in congestive heart failure, we will get raised JVP, or we will get jugular venous distension. Patient will have dyspnea, bilateral crackles on examination, chest examination. If patient has some liver disease, he may have ascites, jaundice. We have to look for proteinuria, oliguria, and also evaluate the thyroid disease if the patient will have anemia, weight gain, fatigue. We have to check for tenderness and temperature changes in the edema. So, key findings which we can get in peripheral edema, in especially acute edema, patient will have a patient may be a case of DVT, cellulitis, trauma, or he may have started some new medications. The chronic edema may suggest us about some systemic disease like congestive heart failure, liver disease, renal disease. Unilateral edema often shows local insult like DVT, cellulitis, venous obstruction, and bilateral edema is suggestive of systemic disease like congestive heart failure, liver disease, kidney disease. Petechic edema suggests lymphedema early stages, and non-tender edema is suggestive of systemic disease like congestive heart failure, renal and liver disease. We can classify edema as pitting edema and non-pitting edema, and pitting edema can be further sub-classified into whether there is rapid recovery or slow recovery. The pitting edema, if it shows rapid recovery, that is recovers in less than 40 seconds, and pitting edema with slow recovery shows recovery slightly delayed. It may take more than 40 seconds. The mechanism involved in the rapid recovery pitting edema is increased oncotic pressure, whereas mechanism involved in slow recovery pitting edema is increased hydrostatic pressure. Pitting edema with rapid recovery will show low serum protein, and the causes are increased protein loss, that is Burns nephrotic syndrome, bowel disease, or decreased intake or synthesis of proteins as seen in patients with kwashiorkor, malabsorption, or liver disease, whereas in patients with pitting edema with slow recovery, patient will have normal serum protein, and the causes are systemic venous hypertension, congestive heart failure, pericarditis, tricuspid valve disease, local venous hypertension because of deep venous thrombosis, inferior vena cava syndrome. The patients of non-pitting edema or browning edema, they do not pit, they don't show any pit or on pressing the shin bone or the tissue, place where we are examining the patient for examining this pitting edema. They don't show pit or recover in few seconds. They are non-tender. Skin shows hyperkeratosis, and it is seen specifically in lymphedema because of lymphatic obstruction. The causes are mixed edema, hypothyroidism, peripheral mixed edema, that is in Graves' disease. When the upper limbs are involved in show non-pitting edema, The probability can be of breast cancer or radiation induced, and lower limb non-petechial edema may be seen in patients with aplasia cutis, congenital precox, TADA, Milroy's disease, and Meek syndrome. Facial edema is seen in trichinosis, hypothyroidism, various allergies, nephrotic syndrome, and angioedema. Neurogenic edema may be secondary to autoimmune dysfunctions. Drug-induced edema is seen with calcium channel blockers like nifedipine, some steroids, estrogen, non-steroidal anti-inflammatory drugs, and insulin. May-Thurner syndrome is chronic unilateral pitting edema due to compression of the left iliac vein by the right common iliac artery against the lumbar spine. Idiopathic edema is chronic bilateral and pitting in females less than 50 years of age. Some female may show edema during the menstrual cycle. Just to sum up, uh, the etiology of edema, causes of peripheral edema are increased hydrostatic pressure, for example, regional venous hypertension like deep vein thrombosis, compartment syndrome, systemic venous hypertension like patients with heart failure, liver failure, patients with increased volume, blood volume, that is pregnancy, premenstrual edema, renal failure, heart failure, drugs like calcium channel blockers, steroids, decreased oncotic pressures because of protein loss that's seen in nephrotic syndrome, preeclampsia, reduced protein synthesis, malnutrition, liver failure, patient who shows increased permeability like in patients with burns, insect bites, cellulitis, allergic reaction, lymphatic obstruction may lead to filariasis, malignancy, post-surgical edema. Other causes are mixed edema, lipedema, and idiopathic medications like thiazolidines, glucocorticoids. The important drugs which are associated which cause edema on prolonged use are the more common are thiazolidines, rosiglitazone, pioglitazone, glucocorticoids, aromatase inhibitors, testosterone, androgen, fludrocortisone, estrogen, progesterone, tamoxifen, various calcium channel blockers like amlodipine, phalodipine, nicardipine, nifedipine, nimodipine, alpha blockers like hydralazine, minoxidil. They all contribute to edema, peripheral edema. The less common causes are antidepressant, trazodone, monoamine oxidase inhibitors, non-dihydropyridine calcium channel blocker like verapamil, diltiazem, anti-Parkinson drugs, rospirinol, pramipexole, and various proton pump inhibitor diazoxide, and non-steroidal anti-inflammatory drugs. They may also contribute to edema. Albert Schweitzer has said, success is not the key to happiness, happiness is the key to success. If you love what you are doing, you will be successful. With this, I conclude my today's topic. Thank you. Keep learning.